Okay, so I guess we're starting. So I'm doing coronary circulation and health and disease. So go to the next page. What we're going to look at in this, I guess, lecture is kind of broadly covering the coronary arteries, the coronary sinus and veins, and also, I guess, what can go wrong and lead to disorders. So we're not really required to know the coronary arteries and veins in too much detail, but I mean, I think arteries is more detailed than veins, but basically what you need to know is the arteries are split into right and left coronary arteries, and then like that's the major branch, and then it's divided into many, many, many small segments. Now, all of these segments are very important to the functioning of the heart, but in questions, you're probably mainly going to be seeing questions regarding the interventricular arteries, but I'll talk about that in a bit. So if we start with the right coronary artery, the segments are the marginal artery, posterior descending artery, SA nodal branch, and the AV nodal branch. So it's really important to know that the SA node and the AV node are both supplied by the right coronary artery. Alongside that, the posterior descending artery is supplied by the right coronary artery only in right dominance. So that's something that I'll talk about in a second. And the right marginal artery supplies the right ventricle and the apex heart. The left coronary artery always has the left anterior descending / intraventricular artery. So that's a really big artery. It supplies quite a bit. It supplies the right ventricle, left ventricle, and the anterior 2/3 of the intraventricular septum, And it also has the left circumflex artery, which supplies the atrium and the ventricle on the left side. And a branch of the circumflex artery is the left marginal branch, which supplies the left ventricle. Now, when I was talking about the posterior descending, there's this thing called a dominance in individuals. So in the majority of cases, people are right heart dominant, right coronary artery dominant, which means that the posterior descending artery is supplied by the right coronary artery. But in certain individuals, the posterior descending artery comes from the left coronary artery, and that leads to some serious problems in case of atherosclerosis or like blockage of the cardiac vessels. And this is because if the person is left heart dominant, that means the entire intraventricular system is supplied by the left coronary artery. And if there is a blockage of the left coronary artery, then that can lead to significant infarcts of the ventricles because the entire interventricular system is supplied by the left side. So that's just something to keep in mind. But I believe that the majority of individuals are right coronary artery dominant. But yeah, that's just a question that you might get. Next, coronary veins. So this is definitely something that I've seen in lots of exam questions. So all of the veins drain into the coronary sinus, which then drains into the right atrium. So in the image, the coronary sinus is a really big vein that traverses the entire heart. So if we look at, again, breaking it up into left and right side, the left side mainly is drained just by the great cardiac vein. So this follows the path of the left anterior descending artery, or the same thing as the left intraventricular artery. The anterior interventricular artery. And the tributaries include both ventricles and the left atrium. So both ventricles and the left atrium will drain into the cardiac vein, which will then drain into the coronary sinus. Now, one thing that's really important to know about the veins is the arteries that they follow, because that's commonly asked in exam questions. So I guess it's really important to know that for the great cardiac vein, that's going with the LAD artery or the anterior interventricular artery. On the right side, the drainage comes from the middle cardiac vein and the small cardiac vein. So the middle cardiac vein drains the posterior interventricular septum. So that follows the path of the posterior descending artery or the posterior interventricular artery. So descending and interventricular are synonymous. Just depends on the question, I guess, or what it says in your text. The small cardiac vein drains the right ventricle and accompanies the right marginal artery. yeah, that's basically all you need to know. So you just need to know those main three veins, great, middle, and small, and what they accompany. So it's going to be anterior interventricular, posterior interventricular, and then the right marginal artery. Okay, so there's a couple of other veins in the heart as well. So there's the left marginal and left posterior IV veins. So the left posterior IV vein is only in the case of left heart dominance, but again, not that important. They also drain into the coronary sinus. And just a small thing to mention is that the cardiac veins that run on the anterior surface of the heart, they drain directly into the coronary. I'm sorry, they drain directly into the right atrium as opposed to the coronary sinus. But that's again really, really low yield. The main things you need to know are just the great, middle, and small cardiac veins and which arteries they follow. Yeah, so coronary artery disease is basically what goes wrong with your coronary arteries. So main thing that you're going to be looking at is atherosclerosis. Most people will get some kind of plaque development throughout their lifetime. It's quite normal. It just depends on, I guess, how bad plaque development is. So it's basically, you will get it to some extent, but how bad it is just depends on a few factors. So there's two types of plaques that you'll develop. So there's stable plaques and unstable plaques. So unstable plaques are the dangerous ones, but first we'll talk about stable plaques. They're going to be present in angina pectoris. So basically what happens there is you've got the plaque that's blocking the blood flow, and that causes that pain on exertion, or like typical symptoms of like shortness of breath and pain when you're like exercising, because it's like hard for the blood to get through the plaques that have built up. Unstable plaques are dangerous because they can rupture, and that leads to acute myocardial infarctions as well as heart failure. So, I mean, I will talk about the different types of plaques and how they appear in a second, but what you need to know is that unstable plaques have been linked to inflammation, but they are difficult to identify just based on inflammation because they share lots of inflammatory markers. Imaging can aid in identification, but anti-inflammatory therapy has been, I guess, cited to reduce atherosclerotic AMIs, or basically an unstable plaque rupture. So that's kind of confirming the link between inflammatory markers and unstable plaques, but it's not really that big of a deal, like to fully understand that right now. Risk factors for atherosclerosis, so we can break them down into non-modifiable and modifiable. So obviously the non-modifiable ones are age, gender, ethnic background, especially South Asian or Indigenous individuals are at a much higher risk of CAD, and as well family history. People who have a family history of coronary artery disease are also at higher risk. In modifiables, I mean, smoking is a risk factor for basically everything, so that's always going to be one. Hypertension, diabetes, hypercholesterolemia, inactivity, obesity, and poor diet. So a lot of these things you might associate with, I guess, unhealthy diet kind of related things, or maybe individuals having a high lipid content within their blood. Now, I'll show you what that leads to in the next slide. So basically what we've got here is just two examples of coronary artery disease. We don't really need to know, I think, too much detail, but what we do need to know is, I guess, how they appear. So first thing is what happens when you have coronary artery disease. You've got a high level of triglycerides, a high level of cholesterol. It leads to plaque buildup, and eventually you're going to form like a big plaque that blocks the majority of your vessel, or the lumen of your vessel, and that leads to that difficulty, like that low blood flow, that exertional symptoms, like you're tired because you're not getting enough blood when you're like exerting yourself. So those symptoms, very common with atherosclerosis. Now, there's two types that I mentioned before, stable and unstable. If we look at the image on the right side, the main things that really sticks out is for a stable plaque, you've got a really thick fibrous cap. And I guess that makes sense because if it's stable, that means it's unlikely to rupture. So the thicker the fibrous cap, the less likely it is to rupture because it's got a strong support system there. So yeah, so a stable plaque has a really thick fibrous cap and a smaller lipid core, whereas a vulnerable plaque or an unstable plaque has a really thin fibrous cap, which can burst at any moment, leading to an acute myocardial infarction, and a big lipid core because of the thin fibrous cap. Okay? So main differentiating features there are the thickness of the fibrous cap and the size of the lipid. So yeah, that's basically all you need.
Okay, so I'll just talk about arteries, arterioles, and how they contribute to distributing blood, which often changes depending on what you're doing. Okay, so the first thing is just general definitions. You're probably aware of these, but so you have your arteries, your arterioles, and your capillaries. So your arteries are the big ones. So like your aorta, you'll probably be familiar with those. In your anatomy. So key features of those that distinguish an artery from an arteriole is that arterioles are mostly elastic tube. There's a lot of elasticity to arteries, which you can imagine, for example, the aorta needs to be able to expand quite a lot with all the blood going through it. And they're also quite large in diameter compared to the other ones. And that's just to reduce the resistance to flow. Then there are arterioles. So these are much smaller and they branch off of the arteries. So the smaller means that there's usually more resistance to the blood flow and they're also less elastic. So arterioles are the structures that and the vessels that will vasoconstrict or vasodilate, and that's what's going to control how much of your blood is being distributed to different organs, depending on whether you're resting or you're exercising. And then you have your capillaries. So this is where your arteries meet your veins, and it's where all the gas exchange and the nutrient exchange happens. So with blood pressure, there's two key types of blood pressure. There's systolic blood pressure and diastolic blood pressure. So systolic blood pressure is the pressure that's in your vessels at that moment when your ventricles contract. So it's going to be the greatest pressure in your blood vessels. And then diastolic is when your ventricles are relaxed. So it's going to be the lowest blood pressure in your vessels. So in systolic blood pressure, so when your ventricles contract, all of that blood gets ejected out, say into the aorta, and it's going to stretch the walls of these arteries. So 2/3 of the blood that's ejected will contribute to that stretching that I just mentioned. But then 1/3 is going to actually flow through those into those smaller vessels like the arterioles and capillaries. Then when your ventricles relax, you get those 2/3 that stretched out the arteries recoiling back in, and then they will flow into the arterioles and capillaries. So regardless of whether your ventricles are contracted or relaxed, so anywhere throughout the cardiac cycle, there's always going to be some blood flow that's going through. So I chucked that question in there. This slide should kind of answer it, but I put in the answer in the notes as well. And just some little definitions here. So hypertension is if someone's blood pressure is consistently above 140/90, and hypotension is if it's consistently below 100/60. And the consistently is important because if someone's blood pressure is just above that range for a one-time visit, it's probably not related to some kind of problem or condition. And with those numbers, they're taken quite loosely. So it's okay if it's like a little bit above or below. Okay, so in terms of measuring blood pressure, we have, I think there might be a bit cut off down the bottom, but so we have your systolic blood pressure, which, as I mentioned before, is the maximum blood pressure in your blood vessels. Diastolic blood pressure, which is, yeah, there we go. I think on there you can see the last value, which I'll get to. So diastolic blood pressure is the minimum pressure in your blood vessels. And then your pulse pressure, that's the difference between your systolic and your diastolic blood pressure. So the difference between the highest and the lowest pressure that can get in your blood vessels. And the mean arterial pressure is this equation here. So it's your diastolic plus a third of your pulse pressure. And just on that graph, you can see there's something called the diacritic notch, and that pretty much happens. I guess if you follow the graph, you can see that that little pulse down, so that little increase, sorry, up, that little increase in blood pressure happens when the aortic valve closes and kind of pushes up a little bit, so you get this little increase in pressure. Okay, now there's also something called Korotkov sounds. This happens, so these are relevant when you're listening to those sounds, maybe in CLIN skills, when you're taking someone's blood pressure. So when you're taking their blood pressure, you usually inflate the cuff to somewhere to a pressure above the systolic blood pressure. And pretty much what that does is it completely closes off the blood vessel that you're listening to. So when you're listening to it, you're not going to hear anything. And then as that pressure slowly releases, you get some turbulent flow going through because the vessel's not completely open, but it's slowly starting to open. And that turbulent flow is going to create sound, and that's what you'll hear as the muffled sound, which will get louder and louder and louder. And then once the cuff is completely, there's no more pressure being like exerted by the cuff, then you will not hear any sound because there's no turbulence and the blood is just flowing through without, and because of the lack of turbulence, there's not going to be any sound. So these are your 5 key like stages in this graph here. Yeah. Okay, now in terms of controlling the arterial diameter. So as I mentioned before, your arterioles are what are vasoconstricting and vasodilating in order to either increase blood flow to somewhere or decrease blood flow to an organ or area in your body. So you have local factors, so things happening at the site of where that blood vessel is, and then systemic factors. So this is either your nerves or hormones that are running through your bloodstream throughout your entire body that will affect this. So under your local factors, there's metabolic control, which is also called active hyperemia, and then myogenic mechanism, and then under systemic, there's neuronal control and hormonal control. So I'll go through each of those now. So in terms of the local factors, the first one is metabolic control or active hyperemia. So this is pretty much where certain chemicals and metabolites that are produced because of increased tissue activity somewhere is going to lead to vasodilation and then increased blood flow to that region, which kind of makes sense because if there's increased activity in a certain tissue, it kind of signals to your body that there needs to be more blood flow to this region because it's at work a bit at the moment. So the first step is the increased tissue metabolic activity, and that's going to release a bunch of chemicals. So these are the key ones. So you can have certain metabolites, and you're going to have increased CO2 just because of the use of energy and glucose. You're going to get increased H+, and you're going to get decreased oxygen. And these chemicals that are released is going to cause the smooth muscle around your arterioles to relax, which will cause your arterioles to dilate. Now there's the myogenic mechanism. So this is pretty much if you have increased blood flow, usually because of an increased blood pressure. So you kind of have increased pressure against your arterial walls. You get this vasoconstriction, which sounds kind of counterintuitive, but because it will result in a decreased blood flow. The reason why it does sound kind of counterintuitive, but the point of it is to make sure that a certain organ is receiving a consistent amount of blood as opposed to the arterioles having a consistent blood pressure. So it does kind of lead to an increased blood pressure, but it leads to a decreased amount of blood going to those tissues. So if you have that sudden increase in arterial blood pressure, it's going to stretch on the walls around it. And if you stretch the smooth muscle that is around your arterial walls, you're going to get an influx of calcium into those cells, and it's going to cause them to contract. So the contraction of the smooth muscle is going to lead to vasoconstriction. And because they're smaller, now the arterioles are smaller, you get less blood flow. And this is important for certain structures like your kidneys or your brain, where you need a constant blood flow. But again, as I said before, it can lead to things like hypertension. And then the last one is neuronal control. Sorry, not the last one, but one of the systemic ones is neuronal control, and then we have hormonal control next. So with neuronal control, you have mainly a sympathetic nerve supply to arterioles. You actually don't have any parasympathetic innervation. So vasoconstriction and vasodilation is controlled by sympathetic pathways. So if a sympathetic nerve, so you're probably familiar with the different types of adrenergic receptors. So the alpha-1, alpha-2, beta-1, beta-2, beta-3. So on your smooth muscle cells that are around your arterioles, you have either alpha-1 or beta-2 receptors. And depending on whether noradrenaline reacts with one of those will change whether or not the smooth muscle contracts or relaxes. So if a sympathetic nerve releases noradrenaline and it binds to an alpha-1 receptor, the smooth muscle is going to constrict. Constrict, and that's going to cause vasoconstriction. Whereas if a sympathetic nerve releases noradrenaline and that reacts with beta-2, that's going to cause the smooth muscle to relax and the vasodilation of the arteriole. And then the last one is hormonal control. So these are just some 4 of the main hormones that you should kind of be familiar with, whether they cause vasoconstriction or vasodilation. You'll probably touch on them in more detail in year 2, but I'd say you don't need to know how, but just be familiar with the fact that each one will cause either constriction or dilation. So the first one is adrenaline. This is released by your adrenal glands. Similar to noradrenaline, if it binds to alpha-1, it's going to cause constriction, and if it binds to beta-2, it's going to cause dilation. Then there's angiotensin 2 and antidiuretic hormone. These are both going to cause constriction. And then there's atrial natriuretic peptide, which will cause dilation of your arterioles. So I've just chucked in a little slide here with a table that kind of compiles all of that into whether or not these things constrict or dilate. So that'll be helpful if you're making notes.
Okay, hi everyone, welcome to PHYS. So next we're going to be covering microcirculation, veins, and venous return. First of all, we should differentiate the difference between hydrostatic pressure, also known as blood pressure, and plasma osmotic, also known as colloidal oncotic pressure. So the diagram on the right, where there's filtration going from plasma to interstitial fluid and absorption going from interstitial fluid to plasma, is a summary of the table on the left. So in hydrostatic pressure, we drive filtration. The pressure is exerted by any fluid on the wall of the enclosed space, that being the blood vessel, and plasma is going from plasma to interstitial fluid. On the other side, we oppose filtration because it's going from interstitial fluid into the plasma, and the solvent is going from a lower concentration solution, and it's drawn across the semipermeable membrane, which is the blood vessel, into a higher concentration solution. And a really helpful diagram to refer to is the diagram on the bottom right. So in filtration, the arterial end net filtration pressure is plus 10 millimeters of mercury. So fluid is moving out of the capillary. In reabsorption, it's moving into the capillary, and then in no net movement, it's going in and out, but because it's the same, there's no net movement. Colloidal refers to the solvent from a lower concentration solution going across the semi-permeable membrane into a higher concentration solution. So just keep in mind that inside the blood vessels, the concentration is greater, which is why it's easier to move out than in. Next, hemodynamics. So the diagram on the right looks quite confusing, but it tells us a lot in the bottom one, the pressure. So it tells us that the pressure is really low in the left atrium, but highest in the left ventricle. And we know that's because when the heart contracts, when the muscles in the left ventricle contracts, it's pushing the blood out of the left ventricle and into the aorta. And that's where we're going to have the highest blood pressure. That's systolic pressure. So it's highest in the left ventricle during systole. And so to revise where blood flows, it decreases incrementally from the left ventricle into the aorta, arterioles, capillaries, veins, back through the vena cava into the right atrium, right ventricle, pulmonary arteries, pulmonary veins, and then left atrium. So we know that the blood pressure is lowest in the left atrium, and that could be a question. Capillaries are the site of substances exchange between the blood and the cells of the body. For hemodynamics, this you can just have a look in your own time, the left one. It just summarizes what we already know. And we're going to be emphasizing on number 5, the capillaries. And then on the diagram on the right, it also tells you that it's decreasing from the left ventricle back into the right atrium. And we also see this diastolic pressure. It's like these waves right here. And those waves are what Sayumi was telling you about how the blood will move out, stretch the vessels, and then flow back in. Edema. So there's 2 types of edema, and we'll get to know edema very well this year as well as next year. So pitting edema is when you put your finger and you press into the limb and you leave like a residual indentation. But non-pitting edema is when you press and then it's swelling, but then when you take your finger off, then the limb sort of goes back to normal. There's no indentation. So what are the causes and why they're different? In pitting edema, it's blood. So the fluid that's being retained is blood. What happened, or why fluid is being retained, is when you have reduced cardiac stroke volume, it means the volume of blood that's being ejected out of the left ventricle, every contraction is less. And that might be because the blood, like the muscle is weaker, or it's unable to sort of keep up with the demands of the body. And so if you've got less blood pumping out every time the heart contracts, you've got more fluid, or more of the blood going from the plasma into the interstitium. So it's going this way because the pressure is higher. That's because there's less blood. So more blood is going into the interstitium, and that means with greater capillary permeability, it means that blood is pooling in your legs and stuff. On the other hand, in non-pitting edema, it's not blood, but it's like fluid. And so that's due to obstruction in the lymphatic system. And so the body isn't able to clear out fluid, and the fluid that remains is water. Top 3 things to know about venous return. So this diagram on the top right is probably the most interesting diagram in the entire lecture. And it tells us a lot about why people might why people are encouraged to sort of, if you can't move, if you can't stand up because you're on a plane, it's a good idea to sort of squeeze your calf muscles to help with blood flow. And we're going to learn about that all in venous return. So the top 3 things to know about venous return, or the top 3 high yield things, are its definition, which is the rate at which blood flows back to the heart and typically equals cardiac output. So cardiac output meaning blood that is being ejected from the heart for every contraction. And if you've got more blood leaving the heart every contraction, you've got more blood going into the systems, more blood going into capillaries, and then more blood going back into the right atrium, back into the heart. The second thing is the relationship between venous return and end diastolic volume. So same thing here. If you've got more blood, end diastolic volume is the amount of blood that's in the ventricle at the end of filling just before contraction happens. So it's how much blood is in there to be pumped out. So you've got more blood there, you're going to get more blood being pumped out and then more venous return. Then number 3 is that venous return is influenced by 3 mechanisms. So the first one is pressure gradient. This one's intuitive. If you've got a higher gradient and blood is moving at a greater force because the sympathetic nerves innervate the veins and they result in the veins contracting. When veins contract, it stiffens the walls up and it increases pressure, and that results in increasing venous return. The other 2 are using pump mechanisms. So B is the skeletal muscle pump. And so when you have increased pumping, you have increased end diastolic volume, which means increased venous return. So it's not actually a pump. What happens is you've got a vein here. Think this is the main one in your leg. And then you've got a muscle that wraps around the veins or is close by. When you squeeze your calf muscles and the muscle contracts, you apply pressure to this part of the vein. And when you apply pressure there, you force the blood that was here to go up. And then that forces blood, or it helps the body pump blood against gravity, and that increases venous return. The third one is respiratory pump, and it uses the same mechanism, but instead of contracting your calves, this time, every time you breathe in, your diaphragm presses downwards, it contracts, and it uses the same mechanisms as your lung pump, and that should increase venous return. I've got a diagram on the next slide. Oh, I don't. Anyway, it's the same mechanism, so it's all good.
Alrighty, so next up we have a bit on ECGs. So I know this can feel a little intimidating, a little daunting. So that's why in these next slides that we're doing, we're going to go through like the foundational level of everything you need to know about ECGs. But if you have any like further questions or anything like that, please feel free to message me and don't stress too much. Once we kind of go through this, you'll see like that foundational level you should have down. So, yep, so as we know, an ECG is used to record like the electrical activity of your heart, and you have these leads that are used as part of the machine. So you can split them up into limb or precordial, and precordial is also like your chest leads. So to start off with limb, you can split that further into standard and augmented. So your standard ones, all of them are bipolar, so they have a positive and a negative end, and so that's lead 1, 2, and 3. And then moving on into your augmented, that's AVR, AVL, and AVF. And then with your precordial, so the other 6 leads, that's V1 to V6. And all of these just have the one positive lead rather than like the 2 separate ends like the other ones. Yep. Okay, so don't be too afraid by all these diagrams. If you just have a look, it's quite straightforward. So on the first one in the top left, you can see where how lead 1 is positioned and how the positive electrode is placed, lead 2 and lead 3. So you can see that even though it's going across the body, you know, you've got that very separate positive and negative electrode. And you can see that in the triangle underneath the actual body diagrams, and that explains it quite easier, especially when we look to the top right, where we're now adding in AVR, AVL, and AVF, and how that all links to the triangle. And as we talk more about like the cardiac axis and whatnot, as we come up to that, that'll make a little bit more sense. And then you can see in the bottom diagram there, those are the chest leads that we have there, so V1 to V6, and that's a very nice diagram of how they'll kind of be positioned. So like V5, V6 will be more kind of to the left, whereas V1 and V2 are more central. So feel free to just use this for some revision if you ever need a bit of a reminder as to where everything is positioned when you put the leads up. Okay, so now into the actual like ECG interpretation. When we're looking at the actual results that we get, whenever we see an upward deflection, that means that there's depolarization towards the positive electrode. So whenever we're talking about the deflections within any of these recordings, we're always going to be talking about in comparison to the positive electrode. So for example, something like the R wave that's there, that's an upward deflection. That's where we're seeing depolarization towards, whereas a downwards deflection would be depolarization away from the positive electrode. And that's why, in particular, the lead AVR is inverted because the positive electrode is facing the opposite way. So if we just want to go to the slide beforehand, sorry. Yep, you can see here that AVL is going towards the positive electrode on the left side. AVF, it's going downwards, but it's not explicitly going to the other side. Oh, no, sorry, my bad. AVR is going to the other side, but it's still going towards the positive electrode, whereas with AVF, we're going downwards for the positive electrode. So when we're recording it, it actually comes up as inverted in comparison to the rest of them. Yeah. So, yep. And then just quickly, before we jump into all of this, just have a quick look at the diagram beforehand of the P, Q, R, S, and T and U waves as well, because now we're just going to go into a little bit more detail on what all of this is. So the P wave, which is the very first initial wave that you see in your whole set, that represents atrial depolarization. So it's always going to be a rounded wave and positive, except for in AVR. And that represents your right atrium, the first half, and then the left atrium, the second half of that P wave. And it should be present in all of your leads. The next step is the PR interval. So in between the starts of the P and R wave. So that's between the start of atrial activation, which is the start of the P wave, all the way to the start of ventricular activation, which is the start of the R wave. So that's very important to know, like that's where it starts and ends. And the PR interval is kind of involving or representing the AV node. Moving on to the QRS complex, that's ventricular depolarization. Q is linked to septal, R is ventricular, and then S is a good representation of the Purkinje fibers. Yep. So moving on to the ST segment. That's where you're seeing a plateau of ventricular depolarization, and it should be an isoelectric line. So isoelectric line as in like it should just be straight horizontal as you would have seen before, like the P wave, for example. And so the ST segment is the interval between depolarization and then the repolarization of the ventricles again. So that's why it should be isoelectric. The T wave, that's representing ventricular repolarization from the epicardium to the endocardium. And it should be asymmetrical. So you should see like a steeper sort of decline than you would have the incline. So the incline is nice and gradual and then a steeper decline. Moving on to the QT interval and the U wave. So those two things aren't as much of a priority to us as the rest of it, but we're still going to cover it. So the QT interval, that's just the total activity from contraction to relaxation, and it should be equivalent to less than half the distance between two R waves, so from one QRS complex to the next. So yeah, that's just something to keep in mind, but not as important as remembering the others. And then of course the U wave, you know, you're not always going to see it, but that can be a good representation of late Purkinje fibers like repolarizing. But that being said, that's why it's not always going to be seen, because that's not always going to happen. But even when it does, it can still be considered normal. So just something to remember. Yep. Alrighty, so this is just a quick summary of all of the main, like what each wave and interval and complex represents here, just because we covered it without looking at the diagram. So feel free to just go through this in your own time again. As you can see, like all the way from the P wave, which was atrial depolarization, to the T wave, which is ventricular repolarization. And there's also a diagram of the heart underneath that text there, and that's also a good representation showing you how the actual we kind of represent the electrical activity going from the top left and going, top right and going downwards in like a left direction. And that can also, that'll link to what we're about to cover now. Yeah, So now we're moving on into actually interpreting the ECG like in a clinical setting. So whenever you're in a situation where you're looking at your ECG, it's always important to firstly confirm your patient's name and date of birth, because you don't want to have any like mix-ups with your patients, and also checking that the date and time is correct. And then we're also looking for any technical errors that might be present on the page. So first of all, your baseline. So kind of like anytime you're not visibly seeing a wave, your trace line should be isoelectric. So it should be horizontally straight and not be fluctuating at all. And if you're seeing any difference in that, like it's not isoelectric, that could mean that maybe the patient is moved, maybe they're shivering. So that's more of a technical error than anything else. So that's always important to check. Another thing is calibration. So at the very start of your ECG trace, you should see those two boxes right at the start, and just checking that they are 1/2 big squares, like it shouldn't be varied at all. And if that's varied, like say for example it's taller, shorter, wider, anything like that, that needs to be double checked, the calibration then. And then the last thing is the electrodes. So you want to make sure that all of your readings are present in like the correct, first of all, present in general, and then they're present in the correct format. So everything should be, you know, as we discuss it, you know, one should be an upward deflection, one should be downward, except for ABR, which should be inverted. So that's always something to check as well. Yeah, so now we're talking about rhythm and rate of your heart. So when we're talking about regular rhythm, there's a few criteria we have for that. So that's what we consider our normal sinus rhythm. So there's a consistent gap between R waves. There's always a P wave present. Every P is followed by a QRS complex. The QRS complex should be less than 0.12 seconds, and the PR interval should be somewhere between 0.12 to 0.2 seconds. And also, you can read that as 3 to 5 small squares on your ECG. And so when we have an irregular rhythm, that's just any sort of variation of those criteria. And you can have either regularly irregular, which would be that, you know, there's variation in what you're meant to be seeing, but it's consistent. So say, for example, there's consistently an issue with the P wave in every single set that you're seeing. Or you can have irregularly irregular, where it's just a little bit of chaos. Like some may have difference in P wave, some may have difference in QRS complex. There's no like set repetition or pattern happening, even if it's irregular. So when we're talking about the heart rhythm being regular, this is where we want to see what the rate is, and this is how we're going to calculate it. So you're going to measure the distance between two R waves. So you can count the number of squares between the two R waves. And when the rhythm is regular, you just need 1, 2, and then you know that that pattern's going to keep repeating. So if you're counting the number of large squares, you divide that you divide 300 by that number. And if you're counting the number of small squares, you're dividing 1500 by that number. In comparison to when your heart rhythm is irregular, because that way you're gonna get 6 R waves, and you're gonna do a similar sort of thing with different numbers here. So 1500 for large squares, 7500 for small squares, and you're gonna kind of get, you're more aiming for an average, because you're seeing that there's variation between each set that you're seeing. So always remember that when it's regular, you can just do it between 2 R waves, but if it's irregular, you need to get more of an average kind of response. And then we just have the numbers down there for what a normal heart rate would be, so somewhere between 60 to 100 beats per minute, whereas tachycardia would be more than 100, and bradycardia, of course, would be less than 60. Okay, so coming into the cardiac axis, this was something that took me a little while to get the hang of, but hopefully we've got it now and we're going to talk through it now. So the cardiac axis, when we're trying to calculate it, we're looking for the overall direction of the electrical spread within the heart. So that's where we were coming from, talking about the fact that we're going, depolarization happens downwards and towards the left. That's what we're talking about. And we want to make sure that the actual electrical spread is happening in that direction like it's meant to be. So we are taught to use lead 1, lead 2, and AVF, but some people use lead 3, and that's what you can see in these diagrams here. So just follow along with what the Monash curriculum is teaching you. I just thought these diagrams were a good sort of exemplar for us to see what they're kind of talking about and picture it a little better. So as we said, depolarization goes downwards towards the left. So in a normal cardiac axis, lead 2 should have the largest positive deflection out of the 3. So when we're having a look here, if we just want to go to the next slide, please. Yeah, so a normal axis, a normal cardiac axis should be between -30 and +90. So as you can see here, when we're within that range of the cardiac axis, we are seeing that the normal QRS axis is between -30 and 90, as we said. As we're moving into axis deviation, we're going beyond that range. And as we go to the next slide, we'll have a little bit of a chat about what exactly that means. So starting with left-sided deviation. When you're having left-sided deviation, lead 1 is going to have more of a positive deflection, and leads 2 and 3 are going to be negative. So that's something that is going to stand out to you, and you're going to be like, oh, okay, something is a little off here. Based on that, we're going to have a look at this diagram here. So this is just kind of how we see that it's left axis deviation specifically. So we're talking about lead 1 being positive, which means it's going in the direction that it's meant to. So we're okay, so the arrow goes that way. Then we're looking at lead 2, and we're seeing that, okay, so lead 2 there, that's actually going negative. So it's going to go in the opposite direction of that arrow there, if that makes sense. Caroline, I don't know if you're able to like just point out what I'm saying. I'm not sure if I'm explaining it very well without the mouse. Yeah, so instead of going the direction that arrow currently is, it's going the other way. Like, think about it that way, going the other way in your head. So when we're looking at kind of averaging the directions of these leads, it's going to end up falling within the left axis deviation section. As you can see in that other diagram there that we looked at before, that's kind of the range within, whenever the arrow kind of falls within that range, we classify it as left axis deviation. Yep, so for example, with what we saw before, like lead 1 would still be positive, the direction it was meant to go. Lead 2, lead 3 would be going the other direction. So instead of the, I'm not sure it's going the right way for Zoom, but hopefully it's not mirroring or anything. So initially we were going downwards to the left, and now instead it's going this way because the other leads are kind of averaging to go in this direction, if that makes sense. Yeah, I'm not sure if I'm able to give as good of an explanation without like using the mouse or anything. So please let me know if you have any questions, and I'm happy to go through it with anybody if you text me on Facebook. But yeah, so to keep going, for left-sided deviation, this can be associated with inferior myocardial infarction, left ventricular hypertrophy, and just loss of electrical activity within the right ventricle. So this is always something to look out for. And similarly, on the next slide, we have right-sided deviation. Yeah, so to kind of go back to this, sorry, just want to make sure that everything's clear. So currently lead 2 is going in this direction. So when we talk about lead 2 being negative, it would have that downward deflection. Instead, we would be going the other way. Similarly with lead 3, currently it's going this way. If we're talking about it being negative, it would go this way. So we can kind of imagine that we have lead 1 being positive, lead 2 being negative, and lead 3 being negative. And as you can see, all 3 of those arrows, if we have them in our head, it kind of averages out towards going towards this direction. And if we want to get specific numbers, we can do that as well. But just for your general understanding, let's just think of it in terms of the direction rather than the numbers. So as you can see, this would be here, this would be here, this would be here. It would all kind of average out to the direction that this yellow arrow is going here. And that would fall within the left axis deviation section that we see in this diagram. So similarly, we'd see that with right-sided deviation. So lead 3 is the most positive deflection we're seeing out of all of these here, and lead 1 is negative. So very similarly, lead 3 would stay positive, lead 2 would stay positive, but instead of lead 1 being positive here, we'd actually see it going the other way. Even if it's not to the extreme of the other ones, it would still be going more in this direction, and averaging out, all of those arrows would average out to that direction instead of what it usually would be, which is downwards towards the left. And as you can see in this diagram, that falls within the right axis deviation sort of sector. So that's the easiest way I found to kind of visualize it in my head, is seeing those different sectors and kind of finding the average between all of the arrows based on whether the lead is positive, so it's going in the direction it's meant to be, or negative, it's going in the opposite direction. So always good to remember that lead 1 is here, lead 2 AVF, lead 3 AVR, AVL, and this diagram up here has all of the numbers specifically for you. So back to it, right axis deviation is associated with right ventricular hypertrophy, high lateral myocardial infarction, loss of electrical activity in the left ventricle, and right heart strain, such as pulmonary embolism or any chronic lung diseases. Okie doke. So when we're talking about specifically each wave or each interval, what exactly are we looking out for and what are we diagnosing based on that? So with the P wave, it's most clearly observed in lead 2, so that's always a nice place to look for it. And it should be roughly less than 2.5 small squares in both directions. So when we have some variation in that, right atrium hypertrophy, you're going to see tall and tented P waves. When you have left atrium hypertrophy, you're going to see wider P waves. For mitral stenosis, you're also going to see wider P waves present. For the PR interval, you should have an interval of about 3 to 5 small squares in length. And if there's any abnormalities, that means there's a transmission delay between the atria and ventricles, so they're not lining up the way they should be. So when you have less than 3 small squares, that means we're going too fast, and that's classified as Wolff-Parkinson syndrome because there's an accessory bundle that's allowing the AV node to just be skipped, and that's what's kind of keeping it out of time and speeding the process up. Whereas if you have more than 5 small squares in length, that means we're going slower than we're meant to, and that's just because there's an AV block that's leading to a slower signal. So let's talk about AV block. There's 4 different types we can discuss. So first degree, second degree, and third degree, and second degree has those 2 separate types. So in first degree, we're seeing that the PR interval is longer than normal, but QRS is consistently present after the P wave. So this is just a regular thing that's happening, even though the PR interval is longer than we expect it to be. And you can see that in the first ECG trace here. So then the next one, which is second degree, type 1, and also if you're doing some research or something, it might come up as wank back. I'm not sure if I said that right, but yeah, that's something to look out for. So for second degree, we're seeing that the PR interval just keeps getting longer, and then we stop. And then the whole process kind of restarts again. And you can see that here in this second one. So that's different to type 2 of second degree, where the PR interval is a normal length, but the QRS complex is just gone at certain times and then it'll reappear. So it's not consistently gone, but every once in a while, it'll not show up, as you can see in this trace here. And then for third degree, you have a total kind of disassociation of the P wave and the QRS complex because you've kind of lost that link between the atria and the ventricles. The atria, as we know, is beating at 60 to 100 beats per minute because of the node that's in control there. And the ventricles are going 40 beats per minute. So that's why we're just seeing a total sort of disassociation. The atria are going at their speed, the ventricles are going at their speed, and it's a little bit of chaos. So that one is a lot easier to kind of distinguish because third degree is just total chaos between the atria and the ventricles. And you can see that in this last one here. So yeah, you're just seeing like a consistent number of P waves there, and then all of a sudden a random QRS complex, and we're not seeing any sort of link between the two. It's very random. Okay, so QRS complex. So when you have an old MI, you're going to see deep or wider Q waves. And when you have ventricular hypertrophy, you're going to see that the leads are oriented towards the larger side. They will have stronger signals. So for left ventricular hypertrophy, the larger S wave, you'll see a larger S wave in V1 and V2, and the R wave in V5 and V6 will be larger than 7 squares. Whereas in right ventricular hypertrophy, you'll see that there's larger S waves in V5 and V6, and the R wave in V1 and V2 will be larger than 2 large squares. So just to kind of get you oriented with that, let's have a think about in comparison to the left ventricular hypertrophy versus right ventricular hypertrophy. And we'll just see where the leads are kind of present. So you're going to be seeing that you have V1 and V2 and V5 and V6 involved in this, and they're very distinctly on 2 different sides. So V5, V6 is on this side, and V1, V2 is on this side. So that's why we can kind of see that even though, you might have left and right, V1 and V2 are involved, V5 and V6 are involved, and it's kind of interchanged where you're seeing the larger S wave compared to the larger R wave. So just have a look at this diagram if you're getting a little bit confused, and just kind of notice, okay, so for left ventricular hypertrophy, I'll see a larger S wave in V1, V2 on the right side, and the R wave will be larger than expected for V5, V6 directly on that left side. So moving on to the T wave. So in general, the T wave shouldn't be taller than 5 millimeters in the limb leads or 10 millimeters in the chest leads. So the chest leads, as we remember, was V1 to V6, and the limb leads were everything else. So when you have tall T waves, that can represent or show that there's an initial ischemic event. When you have an inverted T wave, that means that there could be ischemia within 24 hours of an MI. And when you see every T wave is elevated, that's a good indicator of hyperkalemia because the heart tissue is just hyperexcited. So all the T waves are being elevated. Moving on to the ST segment. As we said before, ST should be isoelectric, should be just that horizontal straight line. So when you have ST elevation or STEMI, which is ST elevation myocardial infarction, we're seeing a full thickness infarction in comparison to a non-ST elevation MI. So that's where you see ST depression. That's a partial thickness infarct. So just for your reference, this is what an ST elevation can look like, and that's what an ST segment depression can look like. And you can see it's very distinct because the comparison of the normal kind of ST segment would be that isoelectric line. And you can also see here, this is a good representation of or the difference between like which of the leads are lateral or which are considered septal, which are considered anterior, and which are considered inferior. And this can all be linked to which kind of artery is being affected based on what type of STEMI that you're seeing. So when we're looking at anterior septal section, so anterior or septal leads, that's affecting, or it is representative of the left anterior descending artery being affected. When we're seeing STEMIs within the lateral leads, that means that the left circumflex artery is involved. And when we're seeing ST elevation within the inferior leads, so you can see lead 2, lead 3, AVF, that means that the right coronary artery is affected. Yeah, so we're almost at the end. We're looking at common pathologies for the ECG now. So let's talk about atrial fibrillation. This is when the heart's atria is just beating out of coordination with the ventricles. So you're not seeing any P waves. We're just seeing those QRS complexes. We're seeing that it's an irregular pattern. So this is where we're not seeing any sort of set repetition between each beat. It's just kind of all over the place. In comparison to something that a lot of people can get mixed up because they sound a little similar is atrial flutter, so AF. When we're seeing atrial flutter, that means the atria is just beating too quickly. And whenever you're doing your exam, you know, anytime they bring up a sawtooth appearance in an ECG, atrial flutter, always remember. So within your QRS waves, you're seeing a lot of flutter waves because that's your P waves, your atria beating too quickly. So lots of those flutter waves, and then your QRS wave happens. That being said, it's very different in that you're still seeing regular kind of pattern. You're seeing that repetition, even though the actual beat itself is irregular. So this slide here, we won't click on it too much, but this is just kind of showing you the difference between AFib and atrial flutter. And always remember sawtooth. Do not forget sawtooth. Okay, so moving on into atrial ectopic. So this is kind of, and think of it like an extra heartbeat. So the whole cycle of PQRST is just all of a sudden kind of appearing in between normal beats. So as you can see here, this is your beat here, a beat here, a beat here, kind of have a look at it in terms of your R wave. And then you can see that this one here, it doesn't really look like the rest. It doesn't look like it's spaced out the same as the rest of them. And that's what we consider like an atrial ectopic beat. That's just an extra heartbeat that's kind of applied itself. Other than that, the P wave and the QRS complexes can seem abnormal at times. So for example, maybe like this QRS complex here or the R wave here looks a little smaller than the rest of them. So everything should look quite normal except for those random beats that might happen every once in a while. So similarly, we have ventricular ectopic beats. So this is where you have an extra heartbeat, but that's controlled by the ventricles. So you're seeing like more premature QRS complexes without that P wave being involved. And then the QRS complex will look a lot larger and wider. So this one's a little bit easier to kind of point out, as you can see here, a lot more distinctly different than the rest of them. Alrighty, so last one we have, very, very important, is ventricular fibrillation. So we're not seeing any P waves because the atria has just like stopped, or the atria have just stopped contracting to begin with. So it's just the ventricles working overtime. You're going to see wide QRS complexes. We're not seeing any P waves, as I said, and this is a very irregular rhythm. As you can kind of see in comparison to the normal sinus rhythm, it's all over the place. That's just the main thing to remember. The atria has just stopped contracting. The ventricles are working overtime to try and compensate for it, but it's not doing its job. So this is very much a medical emergency. You know, you can't really keep going in that way for an extended amount of time, but the body's doing its best to make up for it. So always look out for this. This is one that's easily recognizable and very important to remember. Yeah, thanks for sticking around for all of that. Let me know if you have any questions.
All right, I am going to finish us off today with some talk on vasodilator agents. So next slide, we're pretty much just going to be covering angina and ways to manage angina in this talk, because that's what the vasodilators are covering. So angina symptoms can often be described as pain, different types of pain, but often severe crushing, potentially radiating, shortness of breath, and female patients may present with nausea or back pain. So angina, you're already seeing, has pretty similar symptoms on presentation to that of an AMI, which is why it's very important to always have AMI considered as a differential, even if you're sure that it's angina. So causes of angina is pretty much just reduced oxygen to the heart muscle. So the demand for the heart is greater than the supply. So that will cause some potentially death of tissue, or just the tissue stops working quite as well. So there's 3 types of angina. So stable angina is chronic angina. Often there's a lot of atherosclerosis in this type of angina, and it's brought about by a demand for oxygen. So an example of this is over-exercising. Unstable angina has some evidence of atherosclerosis. A person with unstable angina also has acute coronary syndrome. And unstable angina is also unpredictable, so it can lead to thrombus formation. So it's more dangerous than stable angina. And then there's also variant angina. So variant angina is caused by the spasm of coronary arteries. There's no atherosclerosis in this type because it kind of comes and goes. So it's just when the coronary arteries spasm that the angina comes on, whereas stable is pretty much constant, and unstable sometimes comes, sometimes goes. So some risk factors for angina include having hypertension, having a very high cholesterol diet, or hypercholesterolemia just in general, and smoking as well, because these can all lead to the buildup of plaque. And precipitating factors include cold, exertion, stress, and large meals. So often people will have an attack or a more acute episode at their angina after incidents like this. So if they've done a lot of exercise, or if they're stressed, or if they've had a massive meal. Okay. So moving on to our PHARM aspect of angina. So we have 3 types of drugs that we use to combat angina. So we have nitrovasodilators, otherwise known as nitrates. So this increases the vasodilation, which means that the plaques, it's easier for blood to get past the blood vessels. We have calcium channel antagonist, which decreases vasoconstriction. And we have beta-1 adrenoceptor antagonists, which stops the noradrenaline release in the heart. So I'll start with nitrates. So nitrates pretty much release nitric oxide in vascular smooth muscle, and this just imitates the nitric oxide that is already in the heart. So pretty much this causes vasodilation in the veins and the arteries, so it's a relaxant of smooth muscle, and it inhibits the aggregation of platelets, so it means it also stops the formation of thrombi, and it also inhibits leukocyte endothelial interactions. So it's also anti-inflammatory. So nitrates actually have a lot of good properties. So pretty much they relax muscles, they prevent the formation of thrombi, and they prevent excess inflammation. So you don't really need to know too much about the actual process, but I've just put the equation there. So it activates a thing called guanylyl cyclase, which then leads to cyclic GMP, which means that calcium entry isn't allowed in, and the smooth muscle relaxes because there's no calcium channels that are opening and letting the calcium in to contract the smooth muscle. So this nitrates don't have any effect on skeletal muscle or cardiac muscle, so it's just on the smooth muscles. So pretty much just on your arterioles and veins. So that means if you're trying to target something in the heart itself, then you wouldn't use a nitrate. So this is just a diagram showing the MOA. So you can see here where the circle is, you can see the nitrates being added, which then reacts with the guanylyl cyclase and the GTP to cGMP. And then you can see relaxation at the very bottom right, and that's the end goal. So pretty much what we want to do is we want to get our end goal of relaxation. So 2 examples of our nitrate drugs. We've got nitroglycerin, which is administered sublingually or transdermally. Sublingually is for more acute episodes. The effectiveness is only about 30 minutes, and transdermally can last for a day. And then another type, you've got isosorbate dinitrates, which can also be administered sublingually, again for an acute episode, only 2 hours, or orally. Next slide. Nitrovasodilators. So these are the effects of our nitrovasodilators. So it causes venous dilatation, so which causes a decrease in venous pressure and a decrease in the preload, which then leads to a fall in the cardiac oxygen consumption. It also causes arteriolar dilatation, which produces the peripheral resistance and also reduces the afterload. So once again, that leads to a fall in the cardiac oxygen consumption. And it also causes coronary dilatation, so it stops the spasm effect. So pretty much it just leads to a lot of dilatation, and this in turn leads to a fall in the cardiac oxygen consumption in general. So an indication for nitrovasodilators is an acute symptom of, like an acute attack of angina, but you can also use it to prophylactically treat chronic or stable angina. So people who have known angina that's been going on for a long time, if it's stable, as long as it's not unstable or like variant, nitrates can also be used as prophylactic treatment, just because it really does help with that vein dilatation. All right, so some more information. Some limitations. You do have reflex tachycardia due to your lowered blood pressure, because you've got so much dilatation of like your veins and your arterioles. That will lead to a lowered blood pressure, which can also lead to increased heart rate to try and like compensate for that lowered blood pressure. So this can lead to an increase in your oxygen consumption. So it's a little bit paradoxical in that, because you're trying to like reduce your oxygen consumption, but you can have a little bit of reflex tachycardia because of that. But thankfully, like the reflex tachycardia and the increasing oxygen consumption isn't enough to kind of like negate the effects of the nitrates, if that makes sense. And side effects of the nitrates, we've got hypertension, potentially, you've got tachycardia, headache, flushing, and tolerance developing. So all those kind of vasodilators leads to that. All right, next we've got calcium channel blockers. So the method of access is it blocks the voltage operated calcium channels. So this reduces the calcium entry into cardiac cells and leads to a reduction in cardiac calcium. So therefore, there's less vasoconstriction because your smooth muscle isn't allowed to constrict because there's no calcium like influx into the cells. So this is kind of all tying back to when we did semester 1 with like our action potentials. So because there's less vasoconstriction, there's increased vasodilation. So indications, we use this in angina, but you also use it in things like hypertension and tachyarrhythmias. So in angina, which was what we're talking about, it will decrease your total peripheral resistance and also the cardiac work. So it will also reduce the oxygen demand. So when you're considering effectiveness, your most effective calcium antagonist would be verapamil, and then diltiazem, and then nifedipine. But I will cover those in the next slide, I think, or in a few slides. I think it might be in 2 slides' time. All right, calcium blockers and considerations. So some contraindications. You've got 2 classes of calcium blockers. You've got your non-dihydropyridines, but these can actually lead to bradycardias and impaired conduction of the heart. So like you can have atrioventricular block and depressed contractility. So you shouldn't be using calcium blockers, especially non-dihydropyridines, on pre-existing bradycardia, or if somebody is also on beta blockers. You shouldn't be using it on someone who's got conduction problems, and you also shouldn't be using it on someone who has a systolic dysfunction heart failure. So some adverse effects, you've got, like covered before, cardiac depression, you've got bradycardia, flushing edema, headache and dizziness, and you've also got some GIT, some more systemic effects like constipation and nausea. So this is just a method of action diagram. So if you have a look, you've got your calcium channel blockers, which are coming in where the sign says calcium channel blockers, and that's blocking the influx of calcium into the channel. So then that's meaning that because there's not much calcium into the channel, that there's more relaxation of the muscle. You can just have a look at that again. All right. So here we can see the different classes of the calcium channel blockers, like I was covering before. So the dihydropyridines have an effect on the vascular smooth muscle, whereas non-dihydropyridines target the cardiac muscle. So that's just something you've got to remember. So if you have a look here, we've got verapamil and diltiazem, which are both non-dihydropyridines. So they target the cardiac muscle. So they have big cardiac effects. They lead to a decrease in your blood pressure, generally a decrease in your heart rate, and a decrease in your total peripheral resistance. Whereas nifedipine and amlodipine don't have as many cardiac effects, but they lead to a big decrease in your blood pressure, a big increase in your heart rate, and a big decrease in your total peripheral resistance. So this is just something Those are the 4 that you'll really just need to know. Your 2 non-dihydropyridines and your 2 dihydropyridines. And the dihydropyridines are more selective because they kind of just act on your veins and your arteries. Yeah, so they're, as you can see in that little diagram, more vasoselective. Right. Beta blockers. This is our final type of angina drugs. So the method of action is pretty much they block the binding of noradrenaline to the beta-1 receptors, which are in the heart. So in the heart, you've got a whole bunch of receptors, but the most predominant beta ones are your beta-1 receptors. So if you're blocking the sympathetic stimulation to the heart, which is what you do by blocking the binding of noradrenaline to B1, it means that you're in turn decreasing the heart rate. So this in turn decreases the cardiac output. It also decreases the heart rate. It decreases the total peripheral resistance. So it pretty much just decreases the general demand for oxygen of the heart. If we go to the next slide. So indications of this one would be angina, which is actually made worse through exertion. You'd also got arrhythmias, hypertension, people who are post-AMI as well, because you don't want to be working the heart too hard, and stable heart failure. So pretty much things that you're able to control and things that you like you wouldn't use it again for unstable angina. So in angina, the method of action is, so it decreases the cardiac oxygen demand through what I discussed before. The heart rate increases coronary artery perfusion time during diastole. So this is like the relaxation phase, and it also increases oxygen supply to the heart. So the 2 drug names you really need to know is propranolol and metoprolol. So propranolol is a beta-1 and 2 antagonist. So this is non-selective, and I'll discuss that one in a second. So that is probably not the one you'd use for your first line, just because it can have some other effects because it's targeting those beta-2 receptors as well. And metoprolol is a beta-1 antagonist. So this one's more selective. So considerations. So some contraindications to have when considering the use of beta blockers is you wouldn't use it for vasospastic angina. And some adverse effects, you've got, I'm just broken it down into systems. So you've got your respiratory system. Because of the beta-2 blocking effect of our non-selective drugs, we can also have bronchoconstriction because there's a lot of beta-2 receptors in the lungs. So if you're using a beta-1 and beta-2 blocker, then it means that you're really having that effect on the lungs as well. So that's why it's preferable to use the beta-1 blocker. Cardiovascular effects, you've obviously got your decreased heart contractility, you've got bradycardia, AV block, exercise intolerance, and claudication. These are all kind of just like roll-on effects from the decrease in the total cardiac output and the decrease in the contractility and all those sorts of things that are actually like effects of the beta blocking effect. And if the beta blocker is lipid soluble, it can have effects on the brain as well. So it can have can lead to depression, sedation, and sleep problems. So these are also things that you do need to take into account. Like if your patient has a past history of depression, that you'd probably consider giving them a different drug. And diabetes as well, it can mask or exacerbate the hypo or hyperglycemia as well. And they're not quite sure why that is.
Yeah, so I think that's all. And yeah, if you have any questions about anything in Jordan's slides from the last couple of weeks for CLIN Skills, feel free to message him. Also, just super quickly, I think I said the wrong thing for one of the slides. I'll just go back to that. This one here, I just made a bit of an error. AVR is the one that's inverted because the positive electrode faces the opposite way, which I did not communicate very well. As you can see here, AVR, the positive electrode is in the opposite direction to where it would be everywhere else. AVF is still positive and shouldn't be inverted. But yeah, other than that, I think that's us all done. Thank you so much for watching, and please feel free to message any of us if you have any questions.